Good evening. I have the pleasure of introducing tonight Professor Paul Abbott, who is the Winthrop Professor of Clinical Dentistry at the University of Western Australia. He is a specialist endodontist and works in a private practice on a part-time basis. Prior to taking a full-time university position in 2002, he spent 17 years in private specialist endodontic practice in Perth and Melbourne. He was head of School of Dentistry in the University of Western Australia and the director of the Oral Health Centre of WA 2003 and 2009. He has presented over 800 lectures and courses in 42 different countries. He has also published over 170 articles in referred journals and 23 textbook chapters. In 2015, he was appointed as Editor-in-Chief of International Journal Dental Traumatology. He has received numerous awards for excellence in teaching and for services to the dental profession, particularly in education and research. In 2015, he was appointed as Officer of the Order of Australia. Professor Abbott will be speaking to us tonight about Ledermix cement in myths and the scientific facts.
Thank you, Yita, for that introduction, and welcome everybody to this webinar. Firstly, I do apologise for the problems we had with the webinar when we were attempting to do it live recently, and on behalf of the Ausdent company, again, I offer you apologies, and I hope that this re-recording will be much more clear for you. Well, tonight I want to talk about the myths and the scientific facts associated with Ledermix cement. Now, I'll point out from the beginning that whilst I will mention Ledermix paste a little bit with respect to the history of how Ledermix cement was developed, the focus for tonight is not on the paste version of this material. The focus is on the cement version. Now, both of the paste and the cement were developed by Professor Schroeder. Initially, the paste was the first thing that he developed, and that was in 1960, and it became commercially available in 1962. So we certainly have plenty of years of research and clinical use with this material. The cement version was developed in 1962, also, as I said, by Professor Schroeder. And he was a fairly remarkable man in many ways, and also a very nice gentleman. I had the pleasure of meeting with him on one occasion when I visited Switzerland. He had some very significant contributions to the dental profession, not only with the Ledermix materials, but he developed AH26, which is one of the most popular cements around the world. That was followed by the Ledermix paste and then Ledermix cement. And then he veered away a little bit from endodontics for a while, and he developed the ITI implant system. But he maintained an interest in endodontics and published his textbook on endodontics, which was entitled The Science and Practice of Endodontics, in 1981. And you will see some images from that textbook as I go through the lecture tonight. Now, apart from his dental activities, Professor Schroeder was also the chair of the Department of Operative Dentistry at the University of Bern in Switzerland, and then he became dean of the medical faculty, and then subsequently became president of the entire university. So that's the equivalent to a vice-chancellor in the Australian system. So as I said, he was quite a remarkable man and had significant contributions to the dental profession and to education. A little bit of history first before we get down to talking about Ledermix cement, and the history revolves around the use of corticosteroids in dentistry. They were first used to treat temporomandibular joint problems where hydrocortisone was injected into the joint, and it was clear back then with a number of researchers who were using this drug that the action of the steroid was directed against the inflammation that was present in the joint, and that they could only expect to get a permanent result in terms of successful treatment if they also removed the causative factor, such as traumatic occlusion. So that's a really important point to keep in mind, because that's a thing that comes through when we look at other areas of dentistry as well. So around the same time, though, the corticosteroids were used to treat periodontal disease and mucosal disorders, either using them topically or systemically for things like gingivitis. And in a paper published by Fisher in 1956, they compared the use of hydrocortisone to manage gingivitis, both with and without the mechanical cleaning. And once again, they showed that the reduction in inflammation was enhanced if you removed the cause of the factor, in other words, the plaque and the calculus that was present. So it's, again, very important that you do the dental treatment, don't just rely on the drugs. And Weinstein reported the use of topical corticosteroids for other conditions such as leukoplakia, pemphigus, and so on. As far as endodontics goes, the first report of them being used there was for the management of acute apical periodontitis, and there hydrocortisone was flushed through the root canal system after the canals had been prepared. And Wolfson reported that the patients had a very prompt relief of pain. Now this is where Schroeder comes into it a little bit, because he became interested in the use of corticosteroids, but he combined them with an antibiotic, and he reported the use of the corticosteroid antibiotic mixture would reduce the sensitivity to percussion and swelling dramatically. Now it's important to understand what was happening back in the 1950s when these materials were being developed. There wasn't the same understanding of the drugs that we have now, and in particular the thoughts surrounding the use of corticosteroids was that it could suppress the immune response, and therefore infections may become prominent or sort of take over the situation, particularly when we're dealing with things like an infected root canal system. So the concept then was to combine the corticosteroid with an antibiotic to try and overcome the potential problems associated with inflammation. And Schroeder, again, like other authors I've just mentioned, he clearly stated that the treatment with corticosteroids is not a causal therapy, but it's an adjunctive therapy, and therefore you must remove the causative factor by conventional means. He also reported that acute inflammation responded far more successfully than chronic inflammation, and prednisolone, so a synthetic corticosteroid, allowed a much shorter period of treatment than hydrocortisone. Schroeder and his colleague Triaden published many papers back in the early 1960s looking at both clinical cases and also histological studies. Now initially they used hydrocortisone, but then they switched over to triamcinolone. So this was another synthetic cortisone which has 5 times the potency of cortisone or hydrocortisone. And he combined that triamcinolone with chloramphenicol as the antibiotic, and they also included xylocaine as an anesthetic agent in an ointment base. And the concept, and this is taken from his textbook, was to, in terms of using this for pulp capping, was to firstly remove all the caries, so you're removing the cause of the pulp disease, and then they mixed this corticosteroid antibiotic paste into a cotton pledget and placed that over the exposed pulp, and then put a zinc oxide eugenol restoration as a temporary measure. 1 week later, the patient would return it, and they would remove that zinc oxide eugenol along with the pledget, the cotton pledget with the corticosteroid antibiotic paste, and then they would place a hard-setting pulp capping material such as calcium hydroxide, and then restore the tooth as was required. Now they reported the outcomes for 200 teeth using this procedure, and they said that the pain disappeared within 2 to 3 hours, and interestingly, even when there was what they called suppurative pulpitis, which would be today interpreted as irreversible pulpitis, but with a small pulp abscess, so that once the pulp exposure occurred, there was a little bit of pus that exuded through the exposure, but the underlying tissue was irreversibly inflamed. So that's not a situation where you would normally do a pulp cap, but they found that they were able to relieve pain by doing that, and then the majority of the pulps would remain healthy. That would be the pulps that were reversibly inflamed, so with reversible pulpitis, but those suppurative cases would need further treatment, such as root canal treatment. Now that would be expected. It's not a negative against this material, the procedure that they did. It was purely a case of looking at the diagnosis and deciding what the treatment might be. But they were able to show that you could relieve the pain, at least temporarily, by placing this corticosteroid antibiotic mixture on the exposed pulp. Now, as I said, initially they used triamcinolone with chloramphenicol along with xylocaine, and in 1962 they reported that they didn't need to have the xylocaine, and so that was taken out of the mixture that they had, and so it was essentially a triamcinolone chloramphenicol mixture. They then went to the company known as Ledermix Pharmaceuticals, and that's how the name Ledermix originated, and that company wanted to take over the manufacture of that material, but they wanted to change the antibiotic to dimeclocycline, and that was purely for commercial reasons, although nowadays it was actually quite a fortuitous change, because we know that the tetracyclines such as dimeclocycline have excellent anti-resorptive activity, so they will inhibit osteoclasts, dentinoclasts, and cementoclasts. So it was changed, and as I said, it was quite a fortuitous change. Now, Schroeder said that if you're going to do direct pulp capping, the materials you use should have three properties. One is that they should induce dentine. Secondly, they should be antibacterial. And thirdly, they should be anti-inflammatory. But there's no single material then, and even now there's no single material that is likely to have all of these properties in one. And therefore, he said, and I believe, and I support his statement, that it's appropriate to combine materials as long as you're looking at the chemistry of the materials. And so he combined the corticosteroid as the anti-inflammatory agent, an antibiotic as an antibacterial agent, along with calcium hydroxide, which is the dentinogenic agent, and it also has antibacterial action. And as the cement base, he used zinc oxide eugenol, and that also has anti-inflammatory and antibacterial activity. The corticosteroid was used for two main reasons. One was to prevent an acute exacerbation of already inflamed tissues. So if you're treating a tooth with pulpitis, we don't want to exacerbate that condition, so we want to control the inflammatory reaction that's going on. And the corticosteroid is the best drug that will do that for us. The other point he made is that the corticosteroid can prevent necrosis that's caused by the calcium hydroxide that he was including in the material. And I'll show you some examples of that necrosis caused by calcium hydroxide when we look at some histological slides in a little while. The other key thing with the development of this material was that he used zinc oxide eugenol, and the reason for that was that he felt that that would not affect the calcium hydroxide, whereas an alternative cement type material that was used back in those days was zinc phosphate cement. Now, older dentists are probably familiar with that. Zinc phosphate has been used for many, many years to cement things like crowns and inlays in teeth, but also can be used as a base for a restoration or even a temporary restoration. Not so commonly used today. But zinc phosphate is an acidic material, and it was thought that this could neutralize the basic part of calcium hydroxide, so the hydroxyl ion, and therefore make it less effective. So they chose to use the zinc oxide eugenol. Now, Schroeder started by mixing equal volumes of the Ledermix paste that he'd developed, so with the corticosteroid and the antibiotic, with calcium hydroxide powder, and he used that as a pulp cap. So in that same sort of procedure that I outlined early on that he did, instead of mixing the paste into a cotton pellet, he mixed the paste with the calcium hydroxide and applied that as a pulp cap after removing all the caries. So that was really the first use of what we call today a 50-50 mixture, which is very common in endodontics in terms of root canal dressing, but he was using it as a pulp capping material. He would then place a zinc oxide eugenol over that pulp capping material as a hard setting base, and then he restored the tooth at the same appointment. So his thinking here was to try and do this procedure in one appointment rather than in two appointments as he had been doing up to that time. He reported excellent results, rapid pain relief, and the pulps survived when they were reviewed at longer term intervals, and that was using pulp sensibility tests and radiographs to assess whether the pulps had survived. Along with doing the clinical cases, Schroeder also was involved in research, and he did a lot of histological investigations and showed that there was good healing and repair of the pulp without any inflammation in the underlying pulp, and sometimes with some tertiary dentine formation. So if we look at the histological slides here, we see a very healthy pulp here, a odontoblastic layer there, and some hard tissue formation across the pulp exposure. Similarly, in this tooth here, we have a normal looking pulp underneath where the exposure was, and also in the third example here, normal looking pulp and a good hard tissue barrier across the pulp exposure. Now, he showed that in human teeth, which all three of these were, as well as in various animals, including monkeys, with a very similar outcome of healing of the pulps and some hard tissue repair. So he felt that this material is actually achieving exactly what we wanted to achieve with our pulp capping or pulpotomy materials. And so he developed this now as a hard setting cement. He thought, well, rather than having a paste and mixing a powder, the calcium hydroxide powder, and then placing another material, the zinc oxide eugenol, over the top, he thought, well, let's see if we can combine all of those materials into one. And he used the same active substances as in the paste, so the triamcinolone and the dimethylcycline, but for some reason, which I don't know, I wasn't able to find out, but he reduced the concentration. So in Ledermix paste, the triamcinolone is a concentration of 1%, but he reduced it to 0.67% in the cement, so about 2/3 of the concentration. And similarly with the dimethylcycline, he reduced it from 3% down to 2% in the cement, so again about 2/3 of the concentration. And as I said, I don't know why he did that, but that's just what he did. And so he then combined the triamcinolone and the dimethylcycline with calcium hydroxide and also the zinc oxide eugenol. So the rationale here, as I said, was to avoid the need for 2 appointments. So can we just do this procedure in one go? And he felt with this combination of materials, it achieved all the desired therapeutic aims that we want from a pulp capping or a pulpotomy material. And in particular, not just having the therapeutic action, but to have a hard setting material, because that's easier to use, particularly in a pulp capping or pulpotomy situation. Put the material there, let it set, only takes a couple of minutes for it to set, and then you can restore the tooth immediately over the top of that hard setting material, rather than using a paste material, because the paste, when you try to put another material over the top to restore the tooth, the paste can just be smeared across the floor of the cavity, and it's also likely that it's going to be pushed into the pulp where the exposure is, and that may cause some mechanical damage. So with this in mind, Schroeder came up with this combination of material, and that was really the birth of Ledermix cement as we still know it today. And that picture there shows the original packaging, which was used for many, many years when the material was made by Lederle Pharmaceuticals. The more recent version of Ledermix cement, it's now being made in Australia by the Ausdent company, and there you see the new packaging. So what we have here in Ledermix cement is a corticosteroid, that's triamcinolone, 0.67% of the powder. We have the antibiotic, dimethylcycline, which makes up 2% of the powder. And the calcium hydroxide makes up 33% of the powder, so that's 1/3 of the powder. Now, many dentists don't seem to realise that this is the case, and I often get asked questions about can we add calcium hydroxide to Ledermix cement? Well, you just don't need to do it. It's already in there. As I said, 1/3 of the powder is calcium hydroxide. Roughly half of the powder is zinc oxide, and then the majority of the liquid is eugenol. So when the powder and the liquid are mixed together, we effectively have a corticosteroid, antibiotic, calcium hydroxide, zinc oxide eugenol compound, which is a hard setting cement. Now, unfortunately, back in the 1950s and 60s, these two products, the paste and the cement, were somewhat controversial. And in particular, there were various people in the literature, particularly from the United States of America, who were quite active in writing and quite vocal about these materials, expressing all sorts of concerns. The main concerns associated with the cement version was that there might be systemic side effects from the use of corticosteroids. The steroids would not stimulate the calcific repair, and the steroids would lead to chronic inflammation or pulp necrosis. There are also concerns about the use of Ledermix paste. Now, I'm not going to address those tonight, but they were also expressed by these people at the same time. Despite the evidence, and remember, Schroeder published a lot of papers in particularly the early 1960s, which simply showed that these concerns actually did not exist. So, unfortunately, it's very difficult to change people's minds. And I often hear people say that Ledermix is banned in the United States of America. Even today, I still hear this coming from various people. I still hear people saying that Ledermix cement will kill pulps quietly, and I'll come back to that issue in a little while. Well, what I can tell you is that this is fake news. The material has never been banned in the United States of America. It's not only fake news, it's very old news, and it's really time we moved on from this sort of concept or this misperception that Ledermix is a problem and it's not used in America. Well, it may not be used in America, but the reason for that So let's get rid of the myth. The truth is that the company who manufactured the material, Ledermix Pharmaceuticals, never submitted the Ledermix products to the Food and Drug Administration process for approval. They did not see the commercial value in doing it. It was basically a financial decision. Now remember, it was in the 1960s when the material was made. Now I was very fortunate when I was doing my master's degree and some research at the University of Adelaide that I did my research project on the Ledermix products. So I had a lot to do with the materials, but also tried to get the company, this was a few years later, when I had contact with them in 1994, I tried to get the company to market this material and to get the FDA approval so that they could use it in America. Well, unfortunately, their response was that this material is really about a $500,000 product for them per year, and compared to other products which are worth billions of dollars, it's just not worth it. They didn't want to invest money in the process because they thought it was a very small market. And that was despite me trying to persuade them that if they got it into the market would actually grow. But that's the way it was. They weren't interested in going ahead. What they wanted to do was develop other drugs where a patient may take a tablet every day, for instance. Let's just consider something like a cholesterol medication or blood pressure medication and so on. The regular use of drugs like that are worth far more to pharmaceutical companies than a material that's only used occasionally in a dental situation. So it's unfortunate that they never did that, but that's the truth. They just never submitted it for FDA approval. So if we look at some of the concerns, firstly, the systemic side effects of corticosteroids. Well, what we need to do is to look at the amounts that we use in a tooth and the amount of corticosteroid that's released from that material when it's placed inside a tooth. And I used some of the data that I had collected when I was doing my earlier research on both Ledermix cement and Ledermix paste, and we're able to calculate that firstly there's not enough corticosteroid used in a typical treatment of a tooth to have any systemic side effects. There's also insufficient steroid released systemically to have any potential systemic side effects, and particularly when we compared that with the endogenous steroid in humans, both under normal conditions and under stress. And from that paper, I show you the, or part of the graph there. The paper also addressed Ledermix paste, but we'll just look at Ledermix cement tonight. So if we look firstly here on table 1, the endogenous cortisol in humans is around about 20 to 30 milligrams per day. Under a stress situation, that can go up to 300 to 400 milligrams per day. So that's what our body is producing every day and under stress situations. Now, as I said earlier, the triamcinolone that we use in Ledermix has 5 times the potency of cortisol. So we keep that ratio in mind. We then look at what's the maximum amount of Ledermix cement that we could use in a tooth. So I just calculated the surface area of a typical cavity in a large tooth, and it's less than 100 milligrams that we would use. So the maximum amount of triamcinolone that we'd use in a tooth would be about 0.37 milligrams, with the cortisol equivalent of 1.85 milligrams. So even the amount that we're using is way below what our body produces normally. But what we really have to look at is how much of the triamcinolone is released after it's placed, say, in a pulp capping or pulpotomy situation. So when that triamcinolone is released from the material, it's going to diffuse through the dentine, it's going to get into the pulp, and then it will reach the circulation and can go systemically. Well, the reality is that only a very small amount is used, only a very small amount is released. And the cortisol equivalent of what's released within 1 day, and that's over a 24-hour period, it's not immediately, so it's over a 24-hour period, and I'll show you the basis of this calculation a little bit later. The cortisol equivalent is only 1.3 milligrams in a day. So again, it's way below the endogenous cortisol that we have in our systems, and significantly less than the amount of cortisol that is released in a stress situation. So it's fairly simple to conclude from these figures that the potential of Ledermix cement being placed in the tooth and having systemic side effects is zero, or so close to zero that it's not even something we could calculate. The next concern was that the use of a steroid in a tooth in a pulp capping situation would not lead to calcific repair. Well, Schroeder showed, and I've already shown these histological pictures earlier on in the lecture, but Schroeder showed that that is not the case. We do see cases of hard tissue forming over the pulp, which is underneath the pulp there is quite normal and healthy in both those examples. So we do see histological evidence that hard tissue can form underneath Ledermix cement, which contains a corticosteroid. And it was not just Schroeder and his group that showed this, but others did as well, including some Australian researchers, Barry Barker and F.B. Ehrman and Lockett, along with Nigel Clark and Colin Robertson. They all showed similar sorts of things, that typically we get normal pulp tissue in contact with Ledermix cement after doing a pulp cap or a pulpotomy. And underneath that material, in that normal pulp tissue, there are no inflammatory cells. We do occasionally see diffuse calcifications in the pulp, and we occasionally see a dentine bridge. But there are mixed reports in the literature, and I've just said that we occasionally see a dentine bridge, and so that means that we don't always see a dentine bridge. But to me, the question that we should be asking if we're thinking about a dentine bridge is, does it matter whether we get a dentine bridge or not? And my feeling is that no, it doesn't matter at all. Dentine bridge is not essential to say that we've got healing. All the dentine bridge does is make dentists feel good. And I say that seriously because that's what we've traditionally been taught over the years, that your pulp capping doesn't work unless you get a dentine bridge. Well, that's more fake news. The pulp capping works if the pulp recovers and has no inflammation. A dentine bridge is not necessary for healing. All the dentine bridge does is indicate that the pulp has actually been irritated and stimulated to form dentine. But that, again, is not essential for healing. It's not essential in the long term either. A dentine bridge does not provide any protection for the pulp in the future. Dentine bridge is very porous. It lacks the normal structure of dentine. But even normal dentine doesn't prevent bacterial penetration towards the pulp, because dentine is made up of dentine tubules. So we have thousands or tens of thousands of tubules per square millimetre of dentine that reach the pulp. So that means there are tens of thousands of pathways for bacteria to get to the pulp whenever you expose a millimetre of dentine. So if bacteria get to the dentine bridge, it's too late. They're well and truly on the pathway towards causing pulp disease. So the concept that you need a dentine bridge is something that really needs to be reconsidered. The third concern was that the use of corticosteroids would lead to chronic inflammation or pulp necrosis. And once again, I show you the histological slides that you've seen before by Schroeder and many others that show that this simply is not the case. We can get, and we do get, normal healing or normal pulp underneath the Ledermix cement when used as a pulp cap. So the pulp does heal, and it doesn't become chronic inflammation or necrosis. The only time that would occur is if you misdiagnose the condition. So it's really important that we use Ledermix cement in the right situation, and that's where there's reversible pulpitis. There's no point using it with irreversible pulpitis because the pulp is irreversibly inflamed by definition, and that pulp will not survive. The inflammation will continue and the pulp will necrose. So if you've got the right diagnosis, you'll get the right response. So those concerns were not valid in the 1960s, and the evidence was there in the 1960s, and they're certainly not valid today. So we need to move on from those sorts of concerns and think about what we're actually using here. And how does it work? So the actions of Ledermix cement are based on the therapeutic properties of each component that's in it, and removing the different components that we've talked about already. The first thing I want to say here when we're in discussing the different components, is that I don't think the antibiotic is really all that essential to have in there. We have sufficient antibacterial action from the calcium hydroxide and from the eugenol, as you'll see. So why do we need to put an antibiotic in there? Instead, I don't think we need to. And if the material was to be developed today, or if I was developing it, I probably wouldn't put that in there. But it doesn't matter. It's there. It doesn't cause any harm at all. So we use it as that commercial preparation that we can buy. So let's look at the other three main components and the effect that they have. So the triamcinolone, first of all, is our anti-inflammatory agent. And some work done by Rory Hume and his group with Kenny in 1981 demonstrated how much of the triamcinolone is released from this material. Now, this was an in vitro study, and he showed that by the end of the first day, 70% of the triamcinolone had been released from the material and could diffuse through the dentine. And the rest of it was gone by the end of the third day. So, as I said, this was in vitro. Now, you would expect that in vivo, so when you use it in an actual tooth in a patient, we would expect that release and diffusion to be much faster because of the dynamic situation of blood flow in the pulp. So as the drug is released from the cement, it will diffuse through dentine or directly into the pulp if it's a pulp cap or pulpotomy. And once it reaches the pulp, it's going to be cleared very quickly by the circulation, and so the diffusion will be much quicker than it would be in a laboratory situation where you don't have the effects of blood flow. So this means that when we use Ledermix cement in a tooth, there is only a very, very short-term application of the triamcinolone. I would expect that it's not there after about maybe a couple of days. So there's no evidence, as I've already said, that using Ledermix cement will cause pulp necrosis without symptoms. We've already seen the histological slides showing that. But I want to address this point a little bit because for a long time now, I've heard people say that if you use Ledermix cement, the pulp will die quietly underneath there, and you'll have to do root canal treatment at a later stage. Well, that's simply not the case if you have the diagnosis correct. And I stress that again, if you have the right diagnosis. And you should only be using Ledermix cement when you have either a healthy pulp that you're trying to prevent from becoming inflamed, or the more common situation would be where you have reversible pulpitis. So this thing about Ledermix causing pulp necrosis without symptoms is a long-held misconception, and we really need to get over it, as I've said already. I think this misconception arose from inappropriate use of the material, a lack of diagnosis, a poor understanding of the disease processes, and that was all common back in the 1960s. We, as a profession, we didn't have the knowledge that we have today. We didn't have the ability to really differentiate at times between reversible and irreversible pulpitis, and certainly not in a predictable manner. We didn't understand the pharmacodynamics of the corticosteroids. That wasn't until the 1980s when we did the work in Adelaide looking at the release and diffusion of the components from Ledermix into the tooth and surrounding tissues. So there are a lot of misconceptions. The knowledge about corticosteroids wasn't very good in those days either. And I think there are unrealistic expectations of the material. Now, in saying all that, also would like to say that dentists were using this material in an attempt to try and save teeth, which is a very good thing. But dentists back in those days also didn't have the training that dentists have today in terms of doing root canal treatment, particularly in posterior teeth. It was technically difficult to do. Didn't have the instruments that we have today. Just the whole situation was very different. But dentists were trying to save teeth, so they were very likely placing Ledermix cement, this wonderful new material that had come out back then with a promise of pain relief. They were placing it in teeth that should not have had it placed because the pulp was irreversibly inflamed. But the interesting thing is, yes, it did relieve the symptoms for the patient, and effectively it just delayed the inevitable that was going to happen, the pulp necrosis and infection and apical periodontitis. So that was delayed for maybe a a few years before the patient then needed to have root canal treatment or an extraction done then. Now, I'm not saying we should do that to try and delay those things from being done, because again it comes down to the diagnosis, but it does demonstrate that this material is actually very effective in relieving pain. The second component is calcium hydroxide. Now, we know that calcium hydroxide promotes dentine repair. There's numerous studies in that. I'm not going to go through the literature there because I'm sure you're all familiar with it. Now, here I'm talking about hard-sitting cements such as Dical, Life and so on. And it's about 100 years now since calcium hydroxide was introduced into dentistry. So we have an incredibly long history of very successful use of the material and showing good healing rates. There's been an enormous amount of research, and that's histological studies, clinical studies, radiographic studies in animals, in humans, in vivo situations, in vitro studies and so on. And calcium hydroxide shows very consistent findings and results. And we can summarise it with this diagram from Clark's paper. So it's a schematic diagram here. Now, if we were looking at the top of the diagram here is where the calcium hydroxide has been placed. The typical healing response that we find if we look at it histologically is that there's likely to be a layer of debris immediately underneath that. And then there's a layer of necrotic tissue, and that's because of the toxicity of the calcium hydroxide. Remember, it's at a high pH, and basically that's how it works. It causes a surface necrosis, so that necrotic tissue is there. Then there may be some dead blood cells, followed by what's been called a dense zone, and then the calcification or the dentine bridge, if you like. And then underneath that we typically have a healthy pulp. So if we look at many studies, we see the same sorts of findings all the time. That's all good, except we have this 3 layers of debris, necrotic tissue and dead blood cells, which could act as a substrate for bacteria if they're able to get to that part of the tooth. And that can happen, obviously, once the tooth, if it has caries again, or if the restoration that's been placed over the pulp cap, if that restoration breaks down, then bacteria can get back into the tooth. So the bacteria, by the time they get to this area of the pulp cap, may have that substrate to help them set up themselves to continue and cause irritation to the pulp by working their way through the dentine. So potentially a problem is there. That doesn't mean to say that it's always a problem, but potentially it's there. And just to show you histologically, this is from Sveck's work showing that necrotic layer, the calcified or dense zone, and then the dentine bridge, and a very nice healthy looking pulp underneath. Schroeder showed much the same. We see this layer of necrotic tissue, that's a dense zone or the calcified tissue, and then the dentine bridge, and quite a healthy pulp underneath there. And another couple of examples from Schroeder's work. So the pulp exposure would have been here. The necrotic debris has been washed out in the processing for the histological slide in both these examples, and then we see the dentine bridge that's formed there. Now, that's something that you might have actually seen in clinical cases, because this area where the necrotic tissue is can often appear as being like a hole. So you go back into the tooth because there's maybe more caries or the restoration is breaking down, and when you remove the lining that's there, you find that there's this hole underneath it, and it looks often dark, but if you were gently to probe there, you would find that there's a hard barrier underneath, and so you don't need to go and do root canal treatment because you found that old pulp exposure. You simply need to just clean it out and restore the tooth again. So that necrotic layer can manifest as a hole if you go back into the tooth. Now, whilst calcium hydroxide gives fairly predictable outcomes in pulp capping, we have to recognise that nothing's perfect, nothing's 100% in dentistry, and so not all cases with calcium hydroxide will form a dentine bridge, and some cases may have the chronic inflammation persisting, which would then lead to the need for root canal treatment. So it's sometimes going to happen like that. If we compare the healing that we've just seen there with this example, which is from Barry Barker and Effie Ehrman, in a human pulp after having a pulpotomy done, we see that there's normal tissue underneath where the Ledermix cement was placed. Colin Robertson's work was very similar in terms of the results and the healing responses with Ledermix cement. He was looking at premolars that were extracted for orthodontic reasons. And this first one that you see on the screen there now was a tooth that had no restorations and no caries, so it was a clinically normal pulp. And after doing an experimental pulpotomy, there was no inflammation, there was no dentine bridge, but that's okay, we don't need it, remember, as long as we have healthy pulp underneath, and there were no diffuse calcifications throughout the pulp. Whereas in another example from that same study, this particular tooth also extracted for orthodontic reasons, but it had caries before the pulpotomy was done. And so the reaction in this case is slightly different in that we do have a dentine bridge and we have these diffuse calcifications occurring throughout the pulp. So we do see some variety of reactions there. Now the third major component of Ledermix cement is the zinc oxide eugenol. Now eugenol has both anti-inflammatory and antibacterial properties, and I want to show you just a couple of studies that have demonstrated this. And this goes back to Brandstrom's work where he did what was called the upside down restoration. Now this was essentially in human teeth, and again these were teeth that were extracted for orthodontic reasons, but before doing the extraction Brandstrom cut cavities, class 5 cavities into these teeth, and then he restored them in two different ways, which I'll show you in a minute. And after a period of time, the teeth were extracted and examined histologically. Now, the main purpose of this study was to actually look at silicate cement. Now, the younger dentists are probably not familiar with silicate cement, but this was a tooth-coloured material that was used back in the 1970s to restore anterior teeth in the days before we had composite resins. One of the problems with silicate cement was it was believed that it was quite acidic, and so that it could cause post-operative sensitivity in the pulp. And so I was taught to use silicate cement when I was a dental student, and the emphasis was there that you must put a really good lining of calcium hydroxide, such as dical, over all the dentine to act as a buffer to stop the silicate from irritating the pulp. Well, Brandstrom didn't believe that theory. He thought there might be another problem there. So he did these restorations. Now, firstly, he just put silicate cement. And what he found here was that the pulp was inflamed underneath the silicate cement. And when he stained the sections for bacteria, he found that there were bacteria lining the cavity walls and the cavity floor, and the inflammation in the pulp was related to the dentine tubules that communicated with the cavity. Whereas when he put the upside down restoration in place, so it was upside down because he used zinc oxide eugenol as an outer material rather than as an inner material, or a base as we would have called it in those days. So typically you might put, in say in a deep restoration, you might say put a calcium hydroxide lining, then you'd put a base of zinc oxide eugenol, and then you would restore the tooth with amalgam or whatever else was going to be done. So he did it the other way around as part of the experiment because he wanted to test the true effect of silicate on the pulp. And what he found here was that when he put the zinc oxide eugenol outside, so in the outer part of the cavity, there was no inflammation of the pulp and there were no bacteria, basically because the zinc oxide eugenol prevented bacteria from entering the cavity. So it wasn't the acid or the acidic nature of the silicate, it was that the silicate just didn't seal the cavity and it allowed bacteria to get in and cause the pulpitis. So from the perspective of what we're talking about today, the finding from this study that was really interesting is that the zinc oxide eugenol prevents the entry of bacteria into cavities, and that's important. So it shows the antibacterial action. Now, Rory Hume did a series of experiments back in the 1980s looking at how zinc oxide eugenol works, and he reported that when eugenol is exposed to moisture, the eugenol is released through a hydrolysis reaction. Now that can happen at the surface of the restoration, so here because it's going to be exposed to saliva, but also in the cavity where the zinc oxide eugenol will be exposed to the fluid in the dentine tubules. And so that eugenol release will still happen, and the eugenol can diffuse through the dentine and reach the pulp, such as in an indirect pulp capping situation. And Hume was able to measure the amounts of eugenol at various levels there, and we see just below the cavity floor the eugenol is at a concentration of 10 to the minus 2 molar, and then another level in it's 10 to the minus 3 molar. Now at those two concentrations, eugenol is antibacterial. By the time the eugenol reaches the pulp, or just before reaching the pulp, it's dropped down to a concentration of 10 to the minus 4 molar, and at that concentration, eugenol is anti-inflammatory. So it's a fairly unique material in many ways, that it can kill bacteria, but it can also reduce inflammation, and it's concentration dependent as to which of those reactions will occur. And in using zinc oxide eugenol in that situation can lead to pulp healing, so say in an indirect pulp capping, as shown by Schroeder, where in these two very nice cases where we have really good healthy pulps underneath teeth that had a indirect pulp cap with zinc oxide eugenol. So our material, Ledermix cement, has those three major components, and it meets the criteria that Schroeder said we should have for an ideal pulp capping and pulpotomy material. That is, it should be anti-inflammatory, it should be antibacterial, and it should be dentinogenic. And the way we achieve those things is through the components. So anti-inflammatory action from triamcinolone and the eugenol in the zinc oxide eugenol. The eugenol also contributes to the antibacterial action, along with the dimethylcycline and the calcium hydroxide. And the calcium hydroxide has the ability to stimulate dentine formation or hard tissue formation. So in many ways, you'd have to say that this is pretty much the perfect material. There's no other material that I'm aware of that achieves all three of those properties with just a single application of the material. So what are the indications for Ledermix cement? Well, the main indication is reversible pulpitis. And as I've said already a couple of times, it's essential that you have a correct diagnosis. And that's based on your clinical examination, pulp sensibility tests, radiographs, and obviously with the patient history. Now, using Ledermix cement for reversible pulpitis can be done in both deciduous teeth as well as the permanent teeth. You can use it as an indirect pulp cap, a direct pulp cap, or a pulpotomy material, but it's a partial pulpotomy or a full pulpotomy. So there you see it being used as a indirect pulp capping material. You can use it in teeth that do not have symptoms of pulpitis, such as when you have a very deep restoration or deep cavity. You can use it as a lining. So the idea here would be to reduce inflammation that may be present, even though the patient may not have symptoms. If you've got extensive caries, there's certainly a possibility that there may be some chronic inflammation that the patient's just not aware of. And one of the problems when you go in and treat these teeth is that you can exacerbate that inflammatory reaction. So by placing Ledermix cement as a lining before you place your restoration, you can often prevent that acute exacerbation and help the pulp to recover. Now, one of the other problems is that when we do operative procedures on a tooth, we can cause inflammation of the pulp. So again, using the Ledermix cement, particularly relying on the corticosteroid component, can help to reduce the inflammation that we induce as dentists every time we cut dentine. And that applies also to crown preparations. And crown preparation is really quite a severe insult to the pulp, because you're effectively removing all the enamel or whatever enamel is left and exposing a lot of dentine. And remember, when you expose dentine, you're essentially exposing pulp because you're exposing the dentine tubules. So Ledermix cement can be used as a temporary cement to cement your provisional or temporary crowns following your crown preparation. You can also use it in deciduous teeth as a root canal filling material. That could be for cases of either irreversible pulpitis, where you do need to do a pulpectomy, or in cases of an infected root canal system. And one of the advantages of using Ledermix cement as your root filling material in a deciduous tooth is that the material, the Ledermix cement, will resorb at about the same rate that the dentine resorbs as that tooth undergoes its normal physiological resorption as part of its normal exfoliation process. So there are really four main uses for Ledermix cement in dentistry. And I'll just show you a couple of clinical case examples. This first one was a female, she was 26 years old, and she happened to be a dental student. And she had some problems with her 1.5, and she asked me to have a look at it. There was an unsatisfactory restoration. The pulp had all the typical signs of chronic reversible pulpitis, so there was some sensitivity to temperature changes on occasions, but only when it was really cold things or really hot things, and the pain was only there momentarily when the cold thing or the hot thing was on the tooth. So we removed the restoration and placed a Ledermix cement indirect pulp cap along with a glass ionomer. It happened to be Keytac silver as an interim restoration, and her symptoms resolved immediately. I reviewed the teeth at various intervals. Typically I like to review them after 3 months and then another year. And at 18 months, she was undergoing some orthodontic treatment, and they wanted to extract that tooth for space reasons. So being a dental student, she was quite happy to have that tooth examined histologically. And there we see that we have a very normal, healthy looking pulp underneath that indirect pulp cap. This is an older patient. She was 47 years old. She also had chronic reversible pulpitis, and we treated that in a similar way, removed the restoration and the caries, and there was a pulp exposure in this case, so we did a direct pulp cap, and her symptoms resolved immediately. And there you see the 24-month recall radiograph, but we did review it at other intervals, 3 months and 12 months as well. And on that radiograph we see that there's no signs of any periapical changes, and we see that the tooth is responding quite normally to pulp sensibility testing. This was a young girl. It's quite an interesting case where there was a relatively large periapical radiolucency, which the referring dentist thought was coming from 2 teeth, but in fact it was only coming from the 1 tooth, which was the 4-1. And she was referred to our clinic at the dental school, and so she was seen by one of my postgraduate students who was training to become an endodontist. And after doing a thorough examination, including pulp tests, and that's one of the problems, many people don't do pulp tests, and so you don't find out the problem. And even on a tooth that had root canal treatment started, sometimes it's still worth doing a pulp test because you can get surprises. So we investigated that tooth with the thought that maybe the pulp is still in that tooth, and certainly once the student opened up into the tooth by removing the temporary filling in the access cavity, you can see that there's bleeding tissue in there. So a direct pulp cap was done along with restoration, and that patient had no post-operative symptoms, and on review we found normal pulp tests and normal radiographic appearance of that particular tooth. There was no change in the colour of the tooth, as we can see in the clinical photo, and we do see that there's been some pulp canal calcification that's occurred, and that's why we're getting no reaction to the cold pulp test at that 18-month review, and a questionable reaction at the 6-month review. Now, that's normal. When we see pulp canal calcification like that, I don't expect to get a reaction to a cold pulp test. But the good news is we were getting normal reactions to the electric pulp test, and in treating the adjacent tooth, the 4-1, with routine endodontic treatment and a series of long-term dressings, we were able to get good periapical repair. Obviously it needs a little bit more time to repair completely, and the 4-2 maintained itself with a normal pulp. This was another young girl. She'd had trauma to the 2 central incisors and complicated crown fracture of the 1-1. Now we placed a Ledermix cement as a partial pulpotomy in this case, and there were no post-operative symptoms, and she was reviewed at various time intervals up to 3 years, and we see there that the pulp has maintained normal responses to both CO2 and electric pulp test. We had to treat the other tooth, but that was treated immediately. It didn't have a Ledermix cement partial pulpotomy, because of the extent of the fracture and the symptoms that the patient was having. So it's just the one that had the partial pulpotomy, and we have good healing. Likewise with this tooth here, also a complicated crown fracture, a Ledermix cement partial pulpotomy was done, and that also showed good healing, no post-operative symptoms, and that's at the 18-month review. Obviously in this case we also had to treat the 2-1 endodontically because of the periapical involvement and the extent of the fracture of that tooth, but it's the 1-1 that had the partial pulpotomy. In this case we did a pulpotomy. Now there was a complicated crown fracture, again related to trauma, involving the 1-3. And when you see the tooth clinically there, you see that there's virtually no coronal tooth structure left, and somebody had placed a pin in the tooth to try and retain a temporary restoration, which in effect didn't work, because when I saw the patient, most of it had broken away. So we removed the rest, and there was a pulp exposure there, so we placed Ledermix cement as a pulpotomy agent there because of the depth that we're at, and the idea here was to preserve the pulp for as long as possible to get further root development, because it was an immature tooth root, so the apex hadn't fully developed, and it's a fairly wide canal. Now we recognised at the time, when we certainly advised the patient and the parents, that this tooth eventually would need to have root canal treatment done, followed by a post-core and a crown. And the plan also was to do orthodontic extrusion of the tooth, because she needed to have orthodontic treatment anyway. But we didn't want to do any of that until we had complete root development. And even after 6 months, we see that we've had further development of the tooth root. So in this case, we've done a pulpotomy with Ledermix cement to preserve the pulp to get further root development prior to having more complicated treatment later on. And it's not just anterior teeth, we will do this in posterior teeth as well. This was a young boy who had acute reversible pulpitis as a result of caries, and you can see on that radiograph that we have incomplete root development of that tooth. So we did a Ledermix cement pulpotomy and a temporary restoration. There you see the post-operative radiograph there. His symptoms resolved immediately, and at reviews at 3 months and 12 months, there were normal pulp testing responses to electric pulp test, and once again I wouldn't expect to have a response to a cold pulp test in a situation like this where we've done a pulpotomy. But the really important thing here is that we don't just rely on pulp test results, we also look at radiographs, and this radiograph shows that we've had further root development and some calcification of the canals. So that tells us that that pulp has survived and it's been functioning quite normally. So all those cases demonstrate the use of Ledermix cement in different situations. And I just want to finish by showing you the results of a study that we did a few years ago now, but we're looking at the management of teeth with reversible pulpitis, where that pulpitis was associated with cracks in teeth. Now, in the study there were 100 teeth that we looked at. Now, 15 of those teeth had extensive involvement, say with a crack, where the crack may have extended into the pulp, or there was very little coronal tooth structure left, and so the tooth needed to have root canal treatment done in order to be able to get some intra-radicular retention, say from a core into the pulp chamber, or perhaps a post in some cases. So those 15 teeth were taken out of the study effectively, and we were left with 85 teeth that had reversible pulpitis, and we treated all of those with Ledermix cement after removing the restorations, any caries and the cracks that were present. So we placed Ledermix cement, and then we placed an interim restoration, which was typically with either Ketac silver, may have had a stainless steel band as well, or it may have been with Ketac fill if we were in an aesthetic situation. And we followed these patients up. So in terms of the immediate follow-up, how long did it take for the patient to have a resolution of the symptoms? Well, in 71% of the cases, they reported that they had no pain from the time the treatment was done. So no post-operative pain and no pain over the following time. 21% took a day to have resolution of symptoms, 6% took 2 days, and 2% took 3 days. Now, what's really interesting here is that the group with the immediate relief of pain, 71%, is entirely consistent with human Kenny's study, where 70% of the corticosteroid was released within the first 24 hours. And then the other cases that took 1, 2 or 3 days is also entirely consistent with that pattern of release. And remember, their study was done in an in vitro situation, and I said earlier on that we would expect the diffusion to be much faster, and so the immediate relief of pain is quite likely related to that process of diffusion. Now, what's also important is not just whether the pain goes away, but whether the teeth recovered over time. And so we followed these teeth up for up to 5 years for most of them, and we see here that of the 85 teeth, 80 of them recovered and remained clinically normal throughout the follow-up period. So that's 94% of them recovered. The one tooth, the pulpitis, did continue, and so root canal treatment was needed. In one tooth, when we reviewed at 3 months, there was evident that it had pulp necrosis, and so therefore root canal treatment was done. There was one tooth where the patient didn't return for enough follow-ups for us to really know. At the early follow-ups, we were not sure whether there was necrosis or not, and as I said, unfortunately, she didn't return to have the final assessment done. So we're not sure about that one. And then there were 2 teeth that developed pulpitis again after the core restoration was done. So in this study, I, as an endodontist, I don't restore teeth, but I will do the initial work on the tooth where we remove the caries, the cracks and the old restorations. We placed our Ledermix cement as an indirect pulp cap, and then we placed an interim restoration such as a glass ionomer, as I mentioned. I would then review the patient at 3 months, and if everything was okay, its pulp tests were normal, radiographic was normal, I would then refer the patient back to their dentist to have the restoration done. And I recommended that after they do the core restoration, if the tooth needed a crown, so do the core and then wait a few weeks to be sure that the tooth is still comfortable, and pulp test the tooth again before going ahead with the crown preparation. And so there were 2 teeth that after they had the core done that developed pulpitis, and so they had to have root canal treatment done. So we see there that when 94% of the teeth not only recovered, and as the previous slide showed, that the recovery in terms of symptoms was very, very rapid, and 71% it was immediate, but 94% of those pulps recovered and remained that way throughout the rest of the follow-up period. So to summarise, Ledermix cement has been used extremely successfully now for almost 60 years. There's significant scientific research that supports its use, and that's clinical studies, it's radiographic studies, it's histological studies, it's in humans and it's in animals. The major function of the components in this compound is the anti-inflammatory action, which comes from the corticosteroid. The second function is the antibacterial action that comes from the dimeclocycline, the antibiotic, comes from the calcium hydroxide, and it comes from the eugenol. And then the third function is that we can also induce hard tissue formation. And unfortunately, there are many, many misconceptions and perceptions about this material. And as I've addressed, it's really time for people to move on from those misconceptions. The evidence is simply not there for all those concerns that people had many years ago. And the empirical nature of people saying it doesn't work, it just kills pulps quietly, it's just simply not true. As I say, we've got to move on from that. Those concerns weren't valid in the 1960s, and they're certainly not valid 60 years later today. So I hope I've addressed the myths for you and killed those myths, and I hope you are now able to look at the science behind this material and look at the facts and the results that's been attained in various studies and continues to happen if you use it clinically in the right situation. So I thank you for your attention, and I hope this has helped you in your clinical practice. Thank you.